everyone. It gives me immense pleasure to welcome you all to this exciting Fever Foundation quiz. As you all know, it's the first ever quiz on fever. It's all related to fever and related condition. And thanks for registering and joining in. So before we go ahead with the quiz itself, I would like to again reiterate the rules of the games. Some of the rules have been sent to you, but I'm going to repeat them so that you'll be very clear when you're playing the game. The rules are the quiz is for postgraduate student only. You have to be PG student to play this game. And the quiz consists of multiple choice questions. The option to be selected by the clicking the button on the text panel. So you have a text panel on the right hand side. You need to click the text button. The video that is being displayed is only for representation purpose. You cannot click on the video. So you please click on the text on the panel which you have text panel next to you on the video. The participants are advised not to leave the platform and enter the YouTube channel. YouTube is only for viewing. You cannot play the game. You cannot play the quiz there. So therefore, please stay on for all the 20 questions on this platform to answer the quiz and to participate in the quiz. So once you submit the answer, it will not be possible to reverse it. There is no negative marking in the quiz. The winner will be maximum fast right answer. Who is the fastest, but he has to give the right answer. Who gives such maximum responses will be the winner. In the event, if there is a tiebreaker round of 3 questions will be done. To answer the quiz then it will be done to decide the winner. And it is advisable to use the laptop and desktop for the better experience of this game. Next slide. So therefore, we request you to advise to participate from a place you have a good internet connectivity as it is being an online quiz. And if found to be any type of foul play, your candidature or your registration will be automatically disqualified. And you should not use mobile phone for getting answers from any of your colleagues sitting nearby. Fever Foundation is not responsible for any form of technical error such as poor internet connectivity, etc. Participation in the quiz implies that participant accept the integrity of these rules. The participants who have given incomplete or inaccurate personal contact details will be disqualified. Non-compliance with the rules of the game results in automatic cancellation of the participant in the quiz and the candidacy for the prize. And please note that first and second winner will be play from each of these zones. For example, you are playing the North Zone. So first and second winner of this this quiz will enter the national level quiz, which will be held in Bangalore on November 5th and 6th, FEFCON 2022. So you will be playing as a team. Right now you are playing as an individual candidature, but at the national level, both of you will become a team, first and second winner, and you will play as a North Zone representative. So finally, the quiz master and the judge's decision will be final, and all of us have to bind by the decision given by them. So I wish you all the best for the quiz. And I would also like to introduce our eminent judges and the quiz masters who are here. So our first quiz master is Dr. Rashna Hazarika ma'am. She is MBBS and MD Pediatrics from PGI Chandigarh. And she is trained in pediatric emergency and intensive care at PGI Chandigarh for more than a year. And her areas of interest include pediatric intensive care emergency, pediatric infectious and respiratory disease, and pediatric rheumatology. There are several achievements, awards, and accolades. To name a few, she established the Department of Pediatrics at NEI GRA-HMS at Shillong in 2005 and designed and supervised the whole construction of the first pediatric ICU in the government hospital in northeast of India and made it functional in 2007. And he helped in distinguishing, designing the MBBS syllabus for the same institution in 2008. She has several publications to her credit, more than 50 page publications in various international, national, and regional index journals, such as PubMed, Biomed Central, and she has written several chapters in books. And she's been a researcher. She has conducted a number of multiple projects, multicentric projects under Indian Council of Medical Research, that is ICMR, and International Clinical Epidemiology Network. Other administrative responsibilities she has held, and she's holding are editor of IAP Meghalaya, secretary IAP Guwahati, secretary IAP Assam, and she's the editor of Breeze, the newsletter of IAP Guwahati, and chairperson of scientific committee of East Zone Academy of Pediatrics. And she's been the member of task force of Government of India on COVID-19 preparedness for children. Ma'am, Dr. Rachna, ma'am, it's a pleasure and privilege to have you with us as a judge. Welcome to you, ma'am. Our second judge is Dr. Anand Vasudev, sir. Sir is DNB and Pediatrics, DCP, and he has done FIAP, MNAMS, FIMSA, MICP, USA. He is a senior consultant pediatric nephrologist at Indraprastha Apollo Max Hospital, Holy Family Hospital, New Delhi. He's been the National Vice President of IAP 2020. He's been a Vice Chair of Pediatric Kidney Foundation. He's a visiting faculty at MCW USA, Editor-in-Chief of IAP Textbook of Pediatric Nephrology, Editor of Algorithms in Pediatrics, Editor of IAP Textbook of Radiology. He has been awarded several awards and accolades. Some of the few of them are V. Balagopal Award of IAP Best Paper, Sarla Vaishnav Award of IAP Delhi Best Paper, Young Scientist Award of Department of Science and Technology, Puneet Sharma Oration Award in 2020, Dr. Gopal Sharma Oration at Bihar Pedicon in 2019, over more 50 publications in national and the international index journals, large number of chapters he has written in several books, and he has delivered more than 500 talks in both national and international conferences. Dr. Anand Vasudev, sir, it's a privilege to have you with us, sir. Welcome to the quiz program. So I wish you all the participants best of luck. Now I hand over the session to our quiz master, Dr. Rachna ma'am and Dr. Vasudev, sir. Sir, over to you, sir.
Thank you. Thank you very much for your kind introduction. And first of all, thanks to the Microlab for organizing such a wonderful quiz session for the postgraduates. Not only a learning exercise for the postgraduates, but also for the quiz masters, because there are a few things which we also had to look up into the text, but that was a pleasure. And with that, the other co-host in the quiz would be along with me, Dr. Rachna Das Hazarika from Guwahati, and it will be a pleasure for both of us to take you through these 20 questions in the quiz. And wishing you all the best to all the participants, and do your best. And one thing I want to say that this is like a quiz and it's not your exam. So don't get hassled, don't be very tense, and don't be very purport about it. Just play it like a quiz and try to answer as much as you can without any fear. There is no negative marking, so you won't lose anything. But again, as already told by Dr. Manjula, that you have to be very quick, fast, and your acumen in the subject along with your speed, both these things matter. Of course, luck sometimes would also play a role in it. With that, I think, Dr. Manjula, we can start the quiz.
Sir, you have for them to become familiar, can you play some 3 dummy questions so that they become familiar with the platform? No marks will be allotted to this. Madam, you can.
Dr. Rachna, Dr. Rachna, would you like to convey some message to our youngsters who are on the platform?
I think, all the best. I really enjoyed the Eastern Zone quiz, and I'm sure we're going to have a fantastic evening today. And I think without wasting much time, we should start first with a dummy question, sir, because so that they get used to the pattern. And it's over to you, sir. Vasudev, sir.
Yeah. So, Dr. Krishna, can you, the IT team, who will be projecting the IT team?
Yes, sir. Computer G.
Computer G will be projecting. So, we request the Computer G to start the quiz, and with a bang, wishing everyone good luck, and we can start. Now, coming to the first question, these are all general questions just to apprise you about the pattern and also test your internet connections and your laptops and your skills, and also training your fingers in pressing the buttons as quickly as they can. So the first question comes as, which film in India's official entry for 95th Oscars? Answers are Kashmir Files A, B is uh, Chelo Divas, C is Chelo Show, and D is Triple R. So your time starts now. Right. So computer ji, let us know what is the correct answer. Chelo Show is the correct answer. So let us see how many of the participants had the correct answer, number of movies, and how many of them are really fond of movies and really fond of the current affairs. So let's see the results.
So have you heard of this movie?
No, I haven't seen this movie.
I have heard of Kashmir Files and RRR, but the other two, I mean, obviously, I have not heard.
Yeah.
Oh,
Right.
interesting.
Interesting. So I think there's a division of answers, and nobody was really sure of the correct answer. So it's been a mixed response. Anyway, doesn't matter. These were new movies to us also, so must have been new to many youngsters. So thank you. And computer
Sir,
ji,
actually, I think these PGs don't get time to see movies because of duty.
I doubt that, because in our PG days also, I remember that we used to run for the night shows whenever we were free, or the midday shows, I'm sure. So nice. And computer ji, can we go on to the second question? The round of practice round of the quiz, or second question. Here comes the second question for you. Question is, who is the current Chief Justice of India? Choices are A, Uday Umesh Lalit, B, Mr. Ranjan Gogoi, C, Sharad Arvind Bobde, D, Nathalapati Venkata Ramana. So these are four answers. So your time starts now. Right. Thank you, computer ji. And let's see the results. How many of them are actually into the current affairs and know about our Chief Justice of India? Right. The correct answer is Uday Umesh Lalit. And I think I feel that everyone of us should know that all these prime positions which are in the country, like Chief Justice is one of the very prime positions, like our Prime Minister, President, Chief Justice of India, and we all should be knowing who exactly is holding the topmost post in the Supreme Court. So it's Mr. Uday Umesh Lalit. And let's see the results now. Oh, not very encouraging. So only 21% have given the correct answer, and majority have given about the just retired Chief Justice of India. But again, as Dr. Rachna ma'am said, that most of our PGs are busy in their books and duties, but never mind. So these are only trial questions, and we can go on to the next third question. The third and the last trial question is newly appointed trustee of Prime Minister Cares Fund? Who is the newly appointed trustee of the Prime Minister Cares Fund? And your answers are A. Gautam Adani, B. Ratan Tata, C. Mukesh Ambani, D. Azim Premji. And your time starts now. Computer ji, please log the correct answer. Right. The correct answer is Mr. Ratan Tata. So he's a man of great repute. We all know him for all his philanthropic work in the country, and a man of great stature in our country. So let us see the results. How many of our youngsters voted for Mr. Ratan Tata?
Actually, there are three people. There are three people who are chairpersons, and one of them is Ratan Tata. So I think majority have got it right this time.
Yeah. So I think he's been a popular figure, and 61% is a good number. I think that's the trial questions we've had. So I'm sure now all the PG's youngsters would be ready for the actual quiz, and we can start the actual quiz, and you would have all geared up with the trial rounds. So Computer ji, are we ready with the actual quiz, and can we start the questions? Question number 1, we can go ahead with question number 1, Computer ji. Right. So question number 1 comes as hyperthermia is defined as a temperature more than. Please note the question. Hyperthermia is defined as a temperature more than. Answers are A, 40.5 degrees Celsius, B, 41.5 degrees Celsius, C, 42.5 degrees Celsius, and D, 43.5 degrees Celsius. And your time starts now. Right. Thank you, Computer ji. Let us log the correct answer. Right. The correct answer is B, 41.5 degrees Celsius, which is equivalent to 106.7 degrees Fahrenheit. And let us see the results. How many of our youngsters voted for the correct answer? And in the meantime, while the computer is analyzing the results, we would just like to reinstate that the temperature control is done by the hypothalamic center, which has got a heat regulatory set point, and the hypothalamus would control if it is an euthermic condition. The heat set point is there, and the body temperature tries to reach that heat set point, and the temperature would be idealized, that is the euthermia. When there is fever, the set points gets elevated in the hypothalamus, and the body tries to reach that temperature, and the temperature in the body rises and one gets fever. But when there is a heat stroke, the hypothalamic set point remains where it is, but the body temperature rises. So that is the difference when there is fever and when there is a heat stroke. And that's important because the management also is very different. While we would bring down the temperature when there is fever by giving paracetamol or other agents and by sponging, tepid sponging or cooling. But if it's a heat stroke, then these medications would not work. And we just have to cool the environment and cool the body temperature, and the air has to be cooler, and by sponging, we have to bring down the temperature. Dr. Rachna, anything you would like to add on this question?
I think here, you've already covered most of it. Here, we have to understand that it could be an exogenous cause or an endogenous cause. So in India, the most common exogenous cause is the hot climate during the summers, and that's why we have so many people who have heat stroke and they die. In the exogenous causes, the most important ones are the medications like the anesthetic agents which are used, and they have what is known as malignant hyperthermia. Then some of the endocrine causes like thyrotoxicosis and pheochromocytoma can also lead to hyperthermia. So main thing is that you have to recognize these patients where the skin is very hot and dry, and usually if you don't treat them, then it becomes fatal.
Right, thank you. And Computer Ji, if you're ready with the answers, let us see the correct answers. How many of our youngsters have given the correct answers, and who is the fastest finger? Right. So we have the correct answers being given by 53.8%. And who is the fastest finger? Let us see the response. Dr. Nikita Singh, congratulations. She has taken to answer the question in 4 seconds. Excellent. Congratulations, Dr. Nitika, and keep it up. 4 seconds is really a short time to answer the questions. Congratulations. Thank you, Computer Ji. We can go on to the next question. Right, the next question comes for you. The next question is, rectal measurement of temperature is the gold standard, but it cannot be measured in. Choices are A, thrombocytopenia, B, neutropenia, C, coagulation disorders, and D, abnormal liver function tests. And your time starts now. Thank you, Computer Ji. Let's lock the answer, which is the correct answer. Neutropenia. Neutropenia is the correct answer. So rectal temperature, as we all know, is the gold standard, and it reflects the temperature of rectal arteries. And we normally use it in pediatric population, in newborns also. And being the gold standard, it's very good, especially in measuring the hypothermia. The disadvantages sometimes with measuring the rectal temperature can be that the child may experience pain, there may be sometimes abrasion, and sometimes there's a psychological disturbance, and the children don't like to get the thermometer inserted in their anal area. So that can be a psychological problem, even with older children especially. Perforation is one thing which is actually very rare, and one should not worry about the perforation. It is 1 in million cases, and we have hardly seen any child having perforation with measuring the rectal temperature. Dr. Rachna, would you like to add anything more to the rectal temperature?
Yeah, the only reason we don't want to do it in neutropenic patients is because they would expose them to infections which can be picked up when you insert maybe an unclean or not properly cleaned thermometer. So though this is the gold standard of measurement, but it is very difficult to use rectal thermometers in clinical practice. And that is the reason why we go for auxiliary temperature measurement. But if you have to do research, then yes, rectal temperature is the gold standard. And everything is, sort of, this is taken as a standard for comparison of data. And one has to remember that the rectal temperature is 0.4 degrees more than the axillary temperature. So that has to be kept in mind.
Yeah, we use using rectal temperature, especially in nurseries and in NICU, where the newborns are there, and it's very difficult to take the axillary temperature. So rectal temperature is comparatively easier to take. Thank you, Dr. Rachna. I think we can, if the Computer Ji is ready, we can see the percentage of members voting for neutropenia, choice B. Oh, choice B has been answered by very, very few, only 10%. So I think most of the people would have gone for other answers. And Dr. Sunidhi Singh has given the answer in 7 seconds. Congratulations, Dr. Sunidhi, keep it up. And this is only the second question. So you have 18 more rounds, and we expect you to answer more questions more rapidly. Thank you. Thank you, computer.
I think Dr. Vasudev, this was a very, very important learning question for the participants, where, you know, they have to remember that in neutropenic patients, in those patients with neutropenic fever, you're not going to do a rectal thermometry.
I think most of them who answered more were thrombocytopenia, probably worrying that it might cause some bleeding. But actually, as Dr. Rachna said, it's more related to our worry about the infection being introduced in a neutropenic patient rather than bleeding. And as I said, that injuries are very, very rare with measuring the rectal temperature. Thank you, Computer Ji. I think we can go on to the third question. Here comes the third question for you. The question is, which of the following statements are false regarding pyrexia? The answers are: A, pyrexia is persistence of fever more than 38.3 degrees centigrade. B, pyrexia is persistence of fever more than 37.3 degrees centigrade. C, pyrexia may be caused due to infections, malignancies, and drugs. And D, both A and C. So please note the question very carefully. It says, which of the following statements are false regarding pyrexia? So you have to pick up the false statement, and your time starts now. Thank you, Computer Ji. Let's see which is the correct answer. Let's log the correct answer. Answer B is the correct answer. Pyrexia is persistence of fever more than 37.3 degrees centigrade. And this is equivalent to about 99.1 degree Fahrenheit. And again, anything would you like to talk about pyrexia, persistent pyrexia, Dr. Rachna?
Actually, here the choice is quite evident, because when we say 37.3, we know this is normal temperature. Basically, especially in neonates, we say that 36.5 to 37.4. 37.4 is a normal temperature. So this will be a normal temperature. And in neonates, we say that if it is more than 37.4, then only we consider it to be a hypothermia. And fever per definition is 38.3 degrees centigrade, which is about 101 degrees Fahrenheit. So knowing these very small differences in calculation of the defining fever is very important for clinical practice. Because many a times we get calls from parents, you know, I have a child who is having fever and the temperature is 98.6. So usually they will tell you 98.6, and you already, before you can say that this is normal, they would have already given paracetamol or, you know, even some other anti-inflammatory agents. So educating parents also about what is fever is quite important, and what is the time when you will give an antipyretic agent is also important. So at 37.5, 38 also we may not use antipyretic unless the child is uncomfortable. So by definition, if it is more than 38.3 or more than 101, then we will give some paracetamol. And just to make the child comfortable. We do not want to bring it down to 98.4.
Right. So here what we wanted to highlight was, So the correct answer has been given by 75%, which is again, this was the correct answer?
Yes, this was the correct answer.
Correct answer, yeah, B.
All of them are aware. This is
aware of, yeah.
very good.
So I think that's good that what we wanted to highlight has been picked up by majority of the candidates. And Dr. Kunal Kashi is the winner of this. How many seconds he has taken, Dr. Kunal? And Kunal is probably a boy. Yeah, Kunal is boy. 4 seconds he has taken to answer the question. Very nice. I think most of the youngsters are aware of what is actually not fever, and they should not let the parents worry about that temperature of 37.3 degrees or 99.1 degree Fahrenheit as the fever. So they should be aware about it. Thank you very much. Computer ji, we can go on to the 4th question. Right. The 4th question comes here. This is about the hereditary periodic fevers. And we would like to ask you, hereditary periodic fevers are autoinflammatory disorders characterized by the following, except. Again, please note the question that the following are present, except. Answers are genetic basis. B, may be complicated by amyloidosis. C, may result in malignancy. And D, usually multi-systems with elevation in inflammatory markers. And your time starts now. Right, thank you. And let us see the correct answer, Computer ji. Right, so answer C is the correct answer, that all these are present except that the periodic fevers, hereditary periodic fevers may result in malignancy. They normally would not result in malignancy. And these hereditary periodic fevers are recurrent episodes of fever, and they are autosomal recessive. Mode of inheritance is normally seen in them. And many of these would have pleural and peritoneal inflammation, resulting into sometimes having arthritis, rash, and these are autoinflammatory diseases. Basically, some of these are like familial Mediterranean fever, hyperimmunoglobulinemia D, and they are usually having recurrent fevers, but they do not result in malignancy. So they have genetic basis, may be complicated by amyloidosis, and as already said, multi-system with inflammatory markers also. Dr. Rachna, anything to add in this?
I think you've covered most of the points. Since it is a multi-system inflammatory disorder, so they have involvement of many organs, including the eye and the bones. So some of them may have, they have increased risk for osteoporosis. And actually, there is a defect in the innate immunity, and therefore they are more prone to infections also. And usually there is a defect in the IL-1.
What is the taxi bill, FPA doctors and all that? What is that? Can you please explain to me?
Which one?
Mr. Jairaj, you are asking something? Mr. Jairaj is...
No, he has to be under mute. Can you mute him, please?
Yeah, what is that bill for?
No, Mr. Jairaj, can you mute yourself? Mr. Jairaj?
Okay.
IT people, can you mute Mr. Jairaj?
For which we gave
Mr. Jairaj, sir, can you mute yourself? Jairaj, Mr. Jairaj, please mute yourself.
Abira, please walk up to them. Yeah, walk up to sir now.
It's done, no issues.
Okay,
yeah.
and
Thank you.
most of these, we would have to use an anti-inflammatory like an IL-1 blocker. So then only they will respond. So they may not respond to usual treatment of fever.
Right. Thank you. And Computer ji, if you are ready with the results, let's see. C, 52.63% have given answers. So almost half of you are correct. But I think all the youngsters, I would recommend that you should learn about these uncommon conditions, which are very important for your post-graduations and for your examination point of view. You do see all these infective causes of fever, but these uncommon hereditary periodic fevers and other uncommon conditions, I think you should look into them also, and they are from exam point of view so quite important. So let's see the who has given the correct answer. Dr. Radhesham, congratulations, Dr. Radhesham. You have given the correct answers and the time you have given is 7 seconds. Not very bad. So you try for more questions. We still have a lot of questions to go ahead. Thank you. Thank you, Computer Ji. Can we go on to the next question? Right, we come to the next question. And the question says, what is Mollaret's meningitis? Answers to this are A, recurrent episodes of meningismus, B, chronic recurrent episodes of headache, stiffness, stiff neck and fever, C, cerebrospinal fluid pleocytosis, D, all of the above. And your time starts now. Right. Thank you, Computer Ji. Let's log the correct answer. All of the above. So all these signs of meningismus, CSF changes, recurrent episodes of headache, stiff neck, fever, all these are the symptoms and signs of the Mollaret's meningitis. Dr. Rachna, would you like to tell something more about the Mollaret's meningitis?
It's actually a form of an aseptic meningitis. So there are many conditions which cause aseptic meningitis, like say mumps or measles. You can also get aseptic meningitis. In pediatrics, the most common is mumps, which causes aseptic meningitis. But here, you know, you will not find an organism. Whatever test you do, you will not get an organism. So till now, nobody has known what is the exact cause of a person having these recurrent episodes of aseptic meningitis. Probably there would be some immunological etiology, but we have not till now got the exact pathogenesis or the pathophysiology being described. It was first described by Pierre Mollaret in about 1944. And the description is that the first in the CSF, you get mononuclear cells. So these mononuclear cells were known as Mollaret's cells. And after 24 hours of infection, actually the mononuclear cells convert to lymphocytes. So in the CSF, you will usually get a lymphocytic predominance, but all the others like the Gram stain, the other markers of infection, all these will be negative. So quite uncommon, but I think if you have a person who's coming with repeated episodes of aseptic meningitis, this is something which we must keep in mind.
Right. Thank you, Dr. Rachna. Computer Ji, if you're ready with the result, let's see how many I have given D as the correct answer.
And actually, you don't need to treat this. It resolves by itself.
Oh, great.
Wow.
89% have given correct answer. D is correct answer. And good that I think large majority, almost 90% know about Mollaret's meningitis as such. But this condition, as I was telling you, Dr. Rachna, has not been mentioned by this name in Nelson's textbook. Probably our youngsters are reading other textbooks also other than Nelson to find this Mollaret's. Internet, right. Right, great, great. And let's see who is the fastest finger and the correct answer. Nitika Singh, right. Nitika Singh again, congratulations. Taken 5 seconds. I think she is doing a great job and not only being knowledgeable, but also being fast and quick. Congratulations, Nitika. Keep it up. Thank you, Computer Ji. We can go to question number 6. Right. Now, question number 6 comes with a visual round. And I think most of our postgraduates would be very well aware about this condition. This is a sandpaper rash is seen in this picture. And what is the cause? Is it urticaria? Choice A, urticaria. B, rickettsial fever. C, scarlet fever. D, impetigo. So it's not very difficult. And most of them would be able to answer it very correctly. Can we start the round? Your time starts now. Right. Computer Ji, can you log the correct answer? Scarlet fever, right. And again, it's not very difficult. In scarlet fever, once the fever comes and goes down, there's a sandpaper rash which may appear on the neck and on the upper part of body, sometimes on the arms also. And it's very classical. Once you have seen it, I don't think you will ever forget. And urticaria again is a very common condition which most of us see as hives. These are red patches, normally very itchy. In rickettsial fever, again, there's a palpable purpuric rash along with the platelet count is classically decreased in rickettsial fever. There's usually hyponatremia. The enzymes in liver enzymes as the OTPT are normally raised, and there's clubbing of platelet which leads to a pseudo decrease in the number of platelets. The platelets may actually not be very low, but there is clubbing leading to a pseudo impression that the platelets are low. And again, rickettsial fever is caused by fleas, mites, lice, ticks, and a classical HR sometimes may be seen. And impetigo, of course, we all see day in and day out in our clinical practice with the multiple pustules and children coming, especially in summer and rainy season. So the correct answer is scarlet fever. And so I think this was C, 100%.
Yes.
Oh, that's great.
Excellent.
I think, as I said, that the guess was that by just looking at the picture, almost every one of our post-graduation should be able to give this answer correctly. And I don't think there's anything else to be told about scarlet fever. I think it's quite common entity and they can all recognize it.
It's just because of an exotoxin that you get these appearance of the rash in that particular pattern. So sandpaper means it looks rough, as you would have noticed from the picture.
Right. So I would like Sahil Mittal. Sahil Mittal has given the correct answers in 4 seconds. Expected even a shorter time would have been good enough, but 4 seconds again is a very nice short time. Congratulations, Sahil. Keep it up, and we ask you to answer more questions in the future rounds. Computer Ji, can we go on to the round 7? Seventh question. Here comes question 7 for you. The question is, what are the features of congenital varicella syndrome? The answers are A, cicatricial scarring of the limbs. Answer B, skin involvement in dermatomal pattern. The answer C is a digital defect, and answer D, all of the above. And your time starts now. Thank you. And Computer Ji, let's log the correct answer. All of the above, right? Answer D is correct. All the above are seen. And Dr. Rachna, would you like to say something on the congenital varicella syndrome? We have already told about the features here and a little more about it.
It's a very rare condition, and usually the manifestations, the severity of the manifestations will occur if the mother gets infected during less than 20 weeks of pregnancy. So the more the infection is towards the organogenesis time, the more will be the effect of the various organs. So that's why you see you get digital defects, then scarring of the limbs and skin involvement. And they can vary from, again, person to person. So it is not that all patients will have all findings. So usually the earlier the infection, the more worse will be the presentation.
Right. So we have answer D as the correct answer. And Computer Ji, can we see how many? Oh, great. 89. Again, 90% have given a correct answer, that all the above features. So I think youngsters have read well, though may not have seen the condition clinically, but at least they know all the features of the congenital varicella syndrome. And who is the fastest finger among these 90% correct answer? Kunal Kashi. Kunal Kashi again. I think Kunal had answered the question earlier also. He's again taken 4 seconds. Congratulations, Kunal. Keep it up and answer more questions so that you can be one of the winners. Congratulations again. Thank you, Computer Ji. And we can go on to question number 8. Question number 8 comes to you, youngsters. PGs, be ready. The question is, recurrent fever with abscesses is seen in which condition? The answers are A, hyper IgM syndrome, B, chronic granulomatous disease, C, SCID, D, A-gamma globulinemia. And your time starts now. Thank you, Computer Ji, and let's log the correct answer. Correct answer is CGD, chronic granulomatous disease. I think this is one of the diseases where there are recurrent fevers with abscesses, recurrent infections, and this is hyper IgM syndrome. IgM levels are increased. There's low or absent IgA, IgG, and IgE, and there are recurrent pyogenic infections. While the SCID is a severe combined immune deficiency, and again, SCID usually occurs with a lot of infections in infancy, with the ear infections, interstitial lung disease, sometimes chronic diarrhea, failure to thrive, and oral thrush, which is difficult to treat. And again, A-gamma globulinemia. So all these conditions are the ones which give rise to recurrent fevers and recurrent infections. And I would just ask Dr. Rachna if she needs to add anything more.
I think in CGD, the students have to understand that it's a defect in the NADPH oxidase enzyme. And therefore, the phagocytes are not able to kill the bacteria or the fungus. And that's why you land up with these deep-seated abscesses. The treatment here, the curative treatment is bone marrow transplant. Earlier times when we did not know that bone marrow transplant was cured, we used to keep these patients on chemoprophylaxis with an anti-staphylococcal agent and an antifungal agent. But now we know that BMT is the treatment of choice, and there are lots of success stories from India only for various BMT centers where such primary immune deficiency disorders children have undergone BMT and they're leading a normal life. In the previous one, we had asked one question where we said, you know, malignancy is a cause, but here you have to understand hyper IgM is the one where the patients are prone to get malignancy. Oh, answers are very interesting, sir.
Oh, almost 25% of each of these answers. So I think there's a lot of confusion and not very much of clarity about the chronic granulomatous disease. And I think the students are answering all these SCID as well as the hyper IgM syndrome and A-gamma globulinemia almost equal. Again, CGD again would show a lot of leukocytosis and thrombocytosis as already pointed out, and the treatment has also been, I think again, I would request the youngsters to go into these uncommon conditions also, along with the other routine infectious diseases for fevers and the recurrent infections being seen in the childhood. So let's see who is the... So Safia Soda has given the correct answer, and she has given it in 7 seconds. Not bad, because this was a difficult question and not many of you could answer correctly. But Safia, congratulations and keep it up. Thank you. Thank you, Computer Ji. We can go on to question number 9. Here comes question 9. The question is perceptual distortions of the size, shapes, and spatial relationships seen with the Epstein-Barr virus infectious mononucleosis is called A. Alice in Wonderland syndrome, B. Todd's syndrome, C. Dysmetropia, D. All of the above. And your time starts now. Thank you, Computer Ji. Let's log the correct answer. Correct answer is all of the above. Answer D is the correct answer. And I'm sure many of the youngsters would have heard about the Alice in Wonder syndrome and EB virus infections. The EBV infections are normally, they present with the fever, sore throat, and sometimes malaise, generalized lymphadenopathy. The lymph nodes are enlarged, and that's why sometimes it's also called as glandular fever. And there are atypical lymphocytes, and hepatosplenomegaly normally is the one of the signs which is present. And in this, there is a strangely distortion of body or visual images of size and shape. And that is why the word Alice in Wonderland has been given. And anything more would you like to add about the EBV infectious mononucleosis, Dr. Hazarika?
I think you covered for EBB, but I think what we should understand is that most of these distortions of size, shape, and usually occur more at night. So, you know, the small things would be seen as big, or the big things would be seen as small or crooked that way. And the Todd syndrome is the one which is associated with migraine. So usually this is said to be very classical of migraine, that, you know, when you have severe migraine, then you have distortion in the image which is seen. And most of it's supposed to be the trademark syndrome in migraine. And this is usually treated with migraine prophylaxis in those who have migraine. In others, I think in Alice in Wonderland, in EBV and all would be just symptomatic management. You would not do anything as such. The exact mechanism for this is also not known. How this occurs and why it occurs, it has still not been discovered. So the only one which we can treat here is the Todd syndrome related to the migraine prophylaxis. So we can give anti-migraine drugs for these patients.
Right. I don't think for Alice in Wonderland type of symptoms which would come and disappear. There's anything much which we can do. Right. Computer Ji, can you show us the percentage of students who have given correct answer? D, 65%. Great. I think most of you have read about the EBV infectious mononucleosis, and you have given the correct answer. And who is the fastest finger? Akriti Kumar. Akriti Kumar, okay, a new entrant. She has answered in 6 seconds. Congratulations, Akriti. Keep it up and try to answer more and more questions. Thank you. Thank you, Computer Ji. We can go on to the 10th question. Right, here comes the 10th question. We are almost midway through. And the 10th question says, most common cause of occult bacteremia, fever without focus in a child 3 to 6 months of age. The answers choices are A, Streptococcus pneumoniae, B, E. coli, C, Klebsiella, D, Enterobacter. And your time starts now. Thank you, Computer Ji. Can we lock the correct answer? Right. So the correct answer is Streptococcus pneumoniae and answer A. So Dr. Hazarika, would you like to say something about this particular occult bacteremia caused by the Streptococcus pneumoniae?
Yeah, so the catch in the question was 36 months. So because below 3 months, the organisms, as we know, would be different. Initially, before the vaccination era, when we did not use universal vaccination with the pneumococcus vaccine, this organism, Streptococcus pneumoniae, was supposed to be the most common cause of occult bacteremia. Why occult bacteremia? Because these children would not have a focus. They would actually have a septicemia because of the Streptococcus pneumoniae in the system. And you would not be able to, pinpoint a particular organ system which is involved. And 80% of these would be because of Streptococcus pneumoniae. The rest 10% would be because of H flu. And another 5% would be because of Neisseria meningitis. But now I think if we do a research again on this occult bacteremia in the era of universal H flu, Haemophilus influenzae, and Streptococcal pneumococcus vaccine, I think this data will change. So, but to remember, even now in our country, I think this is important to remember because there are many places we are still not giving pneumococcal vaccine. So this is the number one cause that we should have in mind. And most of the time, if you're lucky, you can culture it if you take a blood culture before giving the antibiotic.
Right. Thank you. Thank you, Dr. Rachna. And Computer Ji, can we see how many have answered A? Again, little divided. So there was some confusion between the bacteria. So answer A is given by 32%.
Actually, they thought of E. coli,
E. coli, yeah.
and negative and all because of but the catch was the age. So above 3 months, it is mostly the gram-positive bacteria.
Right. So 32%, and Amit Mathur has given the correct answers. Correct answer in 5 seconds. Congratulations, Amit. You are the new entrant, so keep it up and try to answer more questions so that you come to as a winner. Thank you, Amit, and congratulations. Thank you, Computer Ji. I would now request Dr. Rachna to kindly continue with the remaining 10 questions. And Computer Ji, can you give the next question, and Dr. Rachna, kindly please take over for the next question.
Thank you, sir. Very well done till now. Let's go to question number 11. Splenomegaly and splenic rupture is a complication of which infection? Adenovirus, dengue, EBV, or all of the above? Your time starts now. So let us look at what is the correct answer. So Epstein-Barr virus. Usually, this is a virus which causes multi-system involvement with, especially in adolescents. And so it is also known as the kissing disease because, it spreads from one person to another by very close contact. And most of these patients, if they have chronic EBV, they will have a lot of fatigue. It takes a lot of time to recover from the infection. And how do we recognize it? We recognize it mostly as a fever with lymphadenopathy, cervical lymphadenopathy, and small splenomegaly. But the point here is that, these patients will have very soft spleen. And therefore, they're very prone to get injured. And if there is an injury, they will rupture the spleen very rapidly. There are many other complications which also occur. EBV virus can also cause meningitis, transverse myelitis, even Guillain-Barré syndrome, and ataxia. So it is not a very simple infection to have. So, sir, would you like to add anything on this?
Fine. I think you have already told that the splenic rupture is mainly because of the subcapsular splenic hemorrhages, and this normally occurs in the second week of the disease. And strangely, the trauma is the underlying cause, but trauma are usually very mild and it is really fatal. So even if there is a splenic rupture, probably most of the children would survive. And even with the mild trauma also, they can have a rupture. As you said, that spleen is very soft and there are hemorrhages. And I think dengue fever, we all know that it has got a different type of fever, rashes, and along with that, the PCV hemoglobin is all increased. So this was a different sort sort of a ball game for as fever is concerned compared to the EBV. And we do have splenomegaly in dengue and other infections, but then we don't have the splenic ruptures being seen in things like dengue fever. Thank you. Thank you.
So let us look at how many people have got it correct. 80% have replied for all of the above, which is not true. So I think, what was happening, sir, was that the questions with all of the above were very easy because they all knew that they had to put all of the above. But I think this was, googly. So they got bowled out. So let's see anyway in the 15% who has got it correct. Fastest, Jivansha Dua. Very good. I think Jivansha, congratulations. You got a correct answer and in good time, 8 seconds. So this I think they should remember, these people should remember that this is EBV and the others do not cause splenic rupture. So can we go to the next question, please? So the following are used in the treatment of FAPA syndrome. So FAPA's syndrome, except low-dose steroids, Montelukast, tonsillectomy, and adenodectomy. Your time starts now. So let us look at what is the correct answer. So here the answer has been given as Montelukast. So this was a question that all others can be used. That means we can use low-dose steroids, we can do tonsillectomy and adenodectomy. Now, FAFA, the full form is periodic fever, aphthous stomatitis, pharyngitis, and adenitis. And this is an inflammatory disorder, an autoinflammatory disorder caused by an inflammasome, which can be of oligenic or polygenic background. And there are some diagnostic criteria. Usually it occurs from 2 to 5 years of age. So the children have to be less than 5 years. They should have recurrent fever with the absence of URI, and at least, they could have aphthous stomatitis, cervical lymphadenopathy, or pharyngitis. And what is interesting is in between, these children are absolutely normal. And nothing works excepting for steroids, tonsillectomy, and adenodectomy. So you want to add anything else?
Right. I think you have said most of the things. Just wanted to tell that this is the most common recurrent periodic fever syndrome in the childhood. And steroid doses we normally give is 1 to 2 milligrams per kilogram as a single oral dose, which suffices. But strange thing here, Dr. Rachna, is that this does not prevent recurrences of the episodes. And in fact, rather, they say that it may shorten the interval between the flares. So if the child is having every 4 to 6 weekly fever, and we give a dose of steroids, so the fever will come down now, but maybe the second episode may occur more frequently. So sometimes it may be working for today, but it may not work for the next time. And another drug, cimetidine, has also been tried in decreasing the recurrences, and almost 1/3 of the it causes recurrences in 1/3 of the patients, not in all of them. So cimetidine again is another drug which can sometimes. And tonsillectomy, adenectomy, as you said, that sometimes doing these procedures brings down the episodes of fever again and again. And PFAPA, when we were students, we were not knowing about this condition earlier. And trust me that we had children who would have fever every 4 to 6 weeks. We didn't figure out the cause, and they would have enlarged tonsils and sometimes lymphadenopathy. And our ENT friends would say, get their tonsillectomy done. And we would say, why remove the tonsils? They are protective in nature. But they would insist, and I can tell you, I have personal experience where I had to get 2-3 children getting tonsillectomy done, and after that their fevers just disappeared. So maybe they were having PFAPA type of a condition where we were not knowing the name of the condition, but we knew the treatment tonsillectomy helped these children, and recurrences did not occur. Thank you. Thank you, Dr. Rachna.
So I think we will look at the answers. How many people got it right? Okay, 42% have got the correct answer, which is not bad, considering that it's a recent, addition to autoinflammatory disorders. And maybe know who is the fastest in this? Kunal Kashi again.
Oh, great.
Great, Kunal.
Yeah, Kunal is doing well. 7
Tough
seconds.
competition. We have 2-3 people who have given fastest answers in the last 12 questions. So let us go to question number 13. So look at the picture carefully and I will give you the history. A 2-year-old child is presented with high fever, poor feeding, sore throat, drooling, and on examination, there are very small vesicles and ulcers, as you can see on both the tonsils and palate. So what is your diagnosis? Herpangina, measles, herpes gingival or acute streptococcal tonsillitis. Your time starts now. So can you just show us the right answer, please? You see, if you look at this, I think most of us will think about tonsillitis, enlarged tonsils. But the catch here is, I think, the high-grade fever with the poor feeding because of these small vesicles which are there in the palate. They're extremely painful. And we are seeing a lot of them these days, usually caused by Coxsackie viruses. And the close differential would be the other forms of vesicular lesions, that is hand, foot, mouth disease. Would you like to add anything, sir, in this?
Right. And in measles, we have rash, but they are coplic spots and the site is not like tonsils. And again, herpes gingivitis, as the name suggests, this is caused by the herpes virus, simplex virus, and there are mucosal hemorrhages, and the vesicles are present in the mouth. Small vesicles are present all over in the mouth, not only in the tonsillar pillars, as seen in herpangina. And again, there may be perioral skin and lips may be involved in gingivostomatitis. So that is how we differentiate between them. And of course, we know about the streptococcal tonsillitis already informed. So we have to see the lesions, where they are occurring, how they are, whether they are in clusters at site, and whether they are like vesicles. So we can differentiate between these conditions.
So can we have a look at the answers? Okay, 40% of the people thought it is streptococcal tonsillitis. But I think you should look carefully at the lesions. In streptococcal tonsillitis, you will not get these dots of red dots surrounded by erythema. They will be more of exudates on the tonsils. And usually streptococcal tonsillitis occurs at 5 to 15 years of age. So in a 2-year-old, the most common would be either hand, foot, mouth disease or herpangina. So Dr. Prabhjot has got the fastest. So congratulations, Dr. Prabhjot. And he took only 5 seconds to answer it. So I think very good. Can we go to the next?
One thing was very clear, that everybody knew that it is not measles. So there was a zero.
Yes.
There was a 0 voting for measles. So they're all very clear about measles. Though they may not have seen coplic spots, because we hardly see measles these days.
Yes. So let us go to the next question. Question number 14. So 5-month-old female child born of consanguineous marriage presented with cough and breathlessness for 8 days. The first child of the family had succumbed to death at the age of 4.5 months. The present child was admitted and treated for sepsis. The patient had oral candidiasis and bilateral purulent eye discharge. Clinical investigations revealed a total lymphocyte count of less than 3,000. And the X-ray picture is shown below, shown there. You can see the X-ray, look at it carefully. So what is your diagnosis? What condition does this child have? A, leukocyte adhesion defect. B, CGD or chronic granulomatous disease. C, DiGeorge syndrome. And D, Wiskott-Aldrich syndrome. Your time starts now. So let us look at what is the correct answer. So DiGeorge syndrome is the correct answer. The answer was there actually in the X-ray, and if you can see the X-ray, there is no thymus. The thymic shadow is not there, and this is a small child, a 4.5 to 5-month-old child with a positive family history. So these are the conditions which is congenital and occurs because of microdeletion in chromosome 22. And there is a defect in formation of the organs involved in the pharyngeal pouch. So there'll be ear defects, there'll be defects of the maxilla, of the tonsils, thyroid, the parathyroid, the aortic arch, and the heart. So most of them would have recurrent infections, early recurrent infections, because of absence of the thymus. The thymus is the one which will give you the T cells. So if the T cells are not there, then you will become prone to early bacterial infections. And not only bacterial, but also fungal. So as you see in the history, there is a pneumonia, there is also oral candidiasis and some eye discharge. And because of the problems with the parathyroid, these patients could also have hypocalcemia. And the treatment of choice is prophylaxis with antibiotics and IVIG recurrent, and of course, completing the normal vaccination process. So would you like to describe anything of the other conditions? So you're on mute.
Okay. So you've already told us about the DiGeorge syndrome. So I would just like to tell a line about the leukocyte adhesion defect, that in this defect, again, there are multiple infections and there's leukocytosis, but no leukocytes are seen in the cells to fight the infection. So though there are a lot of leukocytes present and there's leukocytosis, but at the site of infection, the leukocytes are not present and they do not enter the cell, leading to recurrent infections. Again, we have already talked about the chronic granulomatous disease in detail earlier. There are again non-responding infections, recurrent infections, and leukocytosis, thrombocytosis. And about the Wiskott-Aldrich syndrome, again, we see thrombocytopenia is one of the characteristic finding. Here, the platelet number is not less. There's a low mean platelet volume and decreased platelet size. So what we need to look at in this syndrome is not the platelet number, but the platelet size and the platelet volume, which will give us the idea about the Wiskott-Aldrich syndrome. Right, I think you've already talked about DiGeorge in detail. Yeah. That's it.
In Wiskott-Aldrich, the classical finding is that of eczema. So they have immunodeficiencies, so recurrent infections, they'll have thrombocytopenia, as Sir said, and there will be an eczema. So let us look at the answers. So 37% A, 37% C. Okay. So who has got it correct? Jivansha Dua. Very good. So Jivansha Dua has got the correct answer. We are having very tough competition, sir. Many of these people have got fastest finger 2-3 times. So which is very good. The competition is extreme. Let us go to the next question. Question number 15. So a 5-month-old presented with high-grade fever for 3 days, coryza, mild cough, congested eyes, and maculopapular rash, starting from the nape, which subsequently progressed all over the body. So the choices are there in front of you. Please give the answer. Your time starts now. So the correct answer is measles. So would you like to say something about measles? Because at your time, I think you saw lots and lots of cases of measles.
Yeah, we
What
did
do you see
see,
now?
we used to see a lot of cases of measles, and I think it was quite a dreaded disease earlier because it would have a lot of complications, especially ear infections, pneumonias, and we used to lose many of these children because of the subsequent complications of the measles rather than the measles per se. And again, after the vaccination and the vaccination programs, the disease has starkly come down, and we hardly now see measles. And if we have to teach about the measles, we have to show the picture to the students rather than the cases per se, which is again a good thing. I think not having a disease is better than showing the disease to the students. And again, about the other conditions, we have already talked about the dengue. Again, the rashes in the dengue are classically little different. And we have low platelet counts, which is very classical. And in dengue, we see sometimes islands of white and red sea. And these are when the child is recovering, we see these classical islands of white and red sea. And if you see that, you can assure the parents that now it's probably going to end. The fever has settled and disease is going, and itching also starts along with it. And again, I think nothing much to say about the measles more.
So here, I think the students still need to learn about measles. Keep this particular, the rash is very classical. It starts from the nape or the forehead, and then it progresses. With every fever, there will be a fresh crop of rash which occurs. And coryza and congested eyes, which are sticky, are very important. Don't go away with the fact that you don't need to know about measles because the vaccination is doing quite well. There are many examples of recent times from Western countries where there has been a measles resurgence because they have stopped using the vaccine. So let us look at how many of, I'm sure 100% have got it correct. So let us look at the results.
D.
59.
Oh. No, not. It's disappointing. Only 60%. It's a classic, I think, in our days, classic example that the rash is starting from the behind. We would look at behind the ears immediately. The child has fever and some congested eyes. We would look behind the ears, and if the rash is present, probably we would say that next 5 days the rash will go down. And we used to tell them day 1 on the face, day 2 on the chest, day 3 on the lower abdomen, and day 4 on the legs, and by 5th day it would disappear. And that is how we used to convince them that this is measles and it will take time. Otherwise, these patients were going on to the homeopathy or other alternative medications and local treatments of all types, that this is something bad. But I think 60% we needed 100%.
The final message from this question and the pattern of answer is that all of you need to go and read about measles and remember it, because don't go home with the idea that you don't see them. Once in a while you do see cases. So let us look at who was the fastest and the correct answer. Kunal Kashi. I'm telling you, sir, these boys are very good.
Yes.
Multiple times I've seen.
Very nice.
So very nice. Let us go to the next question. So question number 16. 9-year-old girl had fever, sore throat, and rash for 3 days. The characteristic presentation include acute febrile illness, sore throat, goose flesh, or coarse sandpaper rash within 12 to 48 hours. Most intense at pressure areas such as axilla and groin. Pasteur's line, strawberry tongue and pustule. Desquamation begins towards the end of the first week. What could be your diagnosis? Your choices are classic Koplik spot measles, hand, foot, mouth disease, roseola infantum, or scarlet fever. Your time starts now. So let us look at the correct answer. The correct answer, please. So, sir, I think this, when they have listened carefully to the previous question, they should have been able to give 100%, should have been able to tell that this is scarlet fever, isn't it?
Absolutely, absolutely. I think we have already talked about it in detail when we talked about the sandpaper rash earlier. And right, and I think I would just like to, measles we have already talked about. Hand, foot and mouth disease is something which is, at least in our northern part of the country, we are seeing it so rampant now that some of the schools, junior schools, had closed down of late because the disease was spreading like a wildfire. And again, it's important that the students should know about the hand, foot and mouth disease caused by group A Coxsackie virus. And it normally takes 2 to 7 days. And the rashes are classically on, as mentioned, on hands, feet and the mouth. But these days we are also finding rashes on the elbow, sometimes on the buttocks and even on the groin. So it is not restricting, the rashes are not restricted to these three areas which are mentioned as in the disease itself, but other areas can also be affected. So what's your experience about this disease in eastern part of the...
Epidemic of hand, foot, mouth disease, sir. And every day I'm only seeing 3-4 patients. So the experience is the same with our other colleagues. Some of them have, schools have given, like sort of warned the parents. So most of the parents are not sending. But I think it's what one should remember, it's a very highly infectious disease. And I have been seeing hand, foot, mouth disease for the last 12 years. But this time it has been like too much. It is too much outbreak. Probably because children were at home in the last 2 years and there was some immune deficiency, like, you know, immune, what do you call it? They were not exposed so much. So I think now when they have come out and gone to schools, the exposure is there and the effect of the infection is quite severe. Some of them have stopped drinking, or we had to admit a few patients also.
Oh, really?
Yeah, because of excessive pain in the throat and not able to eat or drink.
So exposure to subclinical infections probably helps these children in building up the immunity, and being at home for last 2-3 years during the COVID times has in fact brought down their immunity. Yeah. So
let us look at how many of them have got it correct. 76.4%, not bad, not bad. So let's see who has got the Kunal Kashi again.
Oh, wow. Great.
Great. So let us go to the next question, please. Question number 17. So again, a long question. Listen to it carefully. A 10-year-old child presented with icterus and altered sensorium. He had taken some herbal medication earlier as a treatment for fever. Investigation showed anemia, thrombocytopenia, a serum bilirubin of 6.2 milligram per deciliter, SGPT of 98. Child had continuous hematemesis and purpuric rashes. And the provisional diagnosis considered were sepsis with multi-organ dysfunction, meningococcal septicemia, and rickettsial encephalitis. Since the child's condition was deteriorating, peripheral smear was carried out and the result shows the presence of Burr cells. So what is the most likely diagnosis? A, purpura fulminans, B, thrombotic thrombocytopenic purpura, C, rickettsial fever, D, dermatomyositis. Your time starts now. So let us look at what is the correct response in this. Correct answer is thrombotic thrombocytopenic purpura. I think in children it is not very common. It is more of a disease in adults. But there is a congenital variation which can be seen, variant of TTP which can be seen, and this mostly occurs in females. And this is because of a congenital absence or deficiency of the von Willebrand factor clearing protease. And therefore, what happens is that the blood vessels get clogged because of thrombus, and therefore there is a multi-system involvement with bleeding, CNS involvement, hematemesis and all. And most of them would respond very well to steroids. So you want to add anything in this?
Yeah, I think one of the treatments which sometimes we require to give to these patients is plasmapheresis. And occasionally we get very sick patients who need this sort of a therapy. And about the other conditions, I think equally important that purpura fulminans, which is again not uncommon to see. It's a very bad disease with necrotic patches, and these children come with gangrene on the ear, gangrene on fingers and toes, and sometimes there's autoamputation. And I think rickettsial fever, we have already talked about it quite a bit. About dermatomyositis, again, these children have recurrent fevers or high-grade fevers, again inflammatory fever with a lot of weakness, and there may be classical heliotrope rash on the eyelids. These are eyelids, the rash appears as purple color. They may be on the eyelid or they may be around the eyelid. And sometimes there is calcinosis cutis also being present. So these are little uncommon conditions, but again, we need to keep them in mind. Once we have these difficult conditions which are mimicking, we should be able to differentiate them. Thank you, Dr. Rachna.
Yeah. So purpura fulminans is Neisseria meningitis, extremely fatal disease if you can't do the diagnosis at the correct time. You may get multisystem involvement and have some icterus in it. But in rickettsial fever, usually there will be transaminitis but no jaundice and no bleeding as such. And in dermatomyositis, as Sir has nicely described, this is an inflammatory disorder, immune related. So here the rash is very classical and there is proximal muscle weakness. So can we see how many people have got it correct?
Oh, great.
Wow, nice. 65%.
Yes.
Let's see who's got the fastest finger. Mehak Bhatt. So very good. Congratulations, Mehak. So can we go to the next question, please? So a 7-month-old breastfed girl child presented with a history of ear discharge at 4 months of age, severe pneumonia and oral thrush. HIV was negative. Chest X-ray revealed the absence of thymic shadow and the absolute lymphocyte count was only 1200. Based on the findings, what is your diagnosis? Is this a case of chronic granulomatous disease, Wiskott-Aldrich, leukocyte adhesion deficiency, or severe combined immunodeficiency? Your time starts now. So let us look at what is the correct answer. So the correct answer is severe combined immunodeficiency or SCID. And if you know about SCID, you will say that this is an X-linked disorder. How come the girl child is affected? Because if it's X-linked, usually it's the males who will get the disease. But here our question says female. So this is also known, it is nowadays known that there are various kinds of SCID. The most common one is X-linked, and the others are because of adenosine deaminase deficiency. So in those ADA deficiencies, you can even have females being affected. Here, it is profoundly deficient in T cells and B cells, and that's why these children at very young age they will get very serious, small infection can become very serious and they succumb very fast. The only modality of therapy is hematopoietic stem cell transplant, which is curative. And nowadays there is a recommendation in some of the countries that how do you diagnose them at birth or immediately after birth. So what they say is that you can look at the blood picture and look for T cell receptor excision circles, which are actually some things, these T cells, they during the process of development, the receptors, they will undergo some breakage and they form circles. So they're byproduct of T cell development. So if you can count these number of cells, if they're there, then means the T cell is functioning well. If they're absent, it is an indirect indicator of that your patient or your baby may have a severe combined immunodeficiency. So would you like to add anything if you've seen any such?
Yeah, I think all these conditions we have described earlier, CGD, Prescott-Eldridge syndrome, and LAD. I think we have already talked about these conditions, and you have quite in detail told us about the SCID also. And I think we can look into the answers.
Yeah. So let us look at how many people have got it correct.
Answer D, very nice, almost
Nice.
55%.
Yeah. 55% have got it correct. Yeah. So let us see who got it the fastest. Jivanshu Dua. Oh, great. Let us go to the next question. Effectiveness of timely hepatitis B immunoglobulin and vaccination in preventing mother to neonate transmission of hepatitis B is more than 70%, more than 90%, more than 95%, more than 80%. Your time starts now. So let us look at what is the correct answer. I'm sure many of them will get it correct. So the correct answer is more than 90%. So it is said that if you have a mother who is hepatitis B positive, then it is immediately we should give an immunoglobulin and also the first or the 0 dose of hepatitis B vaccine to the neonate. And if you can do this, then you are preventing transmission by more than 90% of the cases. So, sir, anything you want to add about this? This is a very important clinical question, actually.
Yeah, and I think with the advent of hepatitis B vaccine and then vaccine being used as a 0 dose right from the birth, in just after the delivery and being availability of the vaccine throughout the country, definitely the incidence has gone down, and the efficacy again is more than 90%. So I think it's a very important modality and the question, and I think we all must be aware about it. Right. Thank you.
So I hope everybody has got it correct. Let's look at the answers, please. Nowadays, we rarely get patients who are mothers who are hepatitis B positive. Very rare.
So the vaccination has improved the status quite a bit, and the availability is acceptability is also good.
Yes. And I think hepatitis B vaccination universally started very early in our country. I remember in 1994, we were given the first dose as students. So I think most of the mothers now are all vaccinated against hepatitis B. So can we have the answers, please? There was a confusion between 90 and 95%.
I think not to blame, because there's a small gap. So 90 and 95, all those who have answered both, I think they are nearly correct, but we have to give it to the correct answer, 90%.
Let us see who got it fast. Sahil Chauhan. Okay, Sahil, very nice. Congratulations. Let us go fast, quickly to the next question, please. A newborn with HIV infection diagnosed with RNA polymerase chain reaction. What is the drug of choice for pneumocystis 0HE? Is it cotrimoxazole, it is trimethoprim, rifampicin, or clotrimazole? Your time starts now. Okay, let us look at the correct answer here. So the answer which has been given is cotrimoxazole. If you can see that in B, we also have trimethoprim, but that alone will not work. It is always trimethoprim with sulfamethoxazole. That's why the correct answer is A. Sir, have you in your clinical practice been seeing patients, newborns with HIV or children with HIV?
No, I think HIV is being seen by our different branch altogether. And in private sector, we don't see much, but in government sector, they are seeing, and they have separate sections who are looking at HIV infection. And I think cotrimoxazole and clotrimazole both were kept here to confuse the but clotrimazole is an antifungal and entirely a different thing, but I think similar names. And again, about this pneumocystis 0HE, I think this is an organism which in all the immunodeficiency syndromes, this is the one and fairly troublesome. And the only drug of choice is clotrimazole. So any of these conditions where there is immunodeficiency and this organism is there, I think we have to be a little careful that not very many choices for its treatment.
Yeah. So even we don't manage HIV patients because we have the NACO which manages so well. So we send the patients to them and they also get the medicines free. And I think for managing patients with HIV infection and disease per se is you have to be totally, into it. You can't do any other thing. It's because of the drugs, the doses. They're so much different from what we normally prescribe. But it is important to know that there is a unit which manages this separately in the government sector, like for TB patients. And what is important is also that for all TB patients, you have to do HIV testing, and for all HIV patients, you have to also look for tuberculosis. So let us look at
because the HIV disease treatment is a prolonged treatment,
yes.
And that's why a dedicated team, as you said, Dr. Rachna, that we need, because the child keeps growing and then the weight keeps increasing and the dosage has to be changed very often. And if these children are seen in OPD basis only, they come once and then they disappear for 6 months. They may be underdosed. So they have to be followed up by a dedicated team who keep a track of them, and then they keep changing the dosage as per their age and weight also.
Yeah. And I think the monitoring is not done with a routine, the routine way we do CBC and all that. It is done by CD4 counts. So that is also available in the government sector. And that's the reason I would not manage any HIV on my own. So can we have the next, the answers? How many people have got it correct?
Oh, great.
Wow, good. They did not get fooled, sir. So let us see who got it the fastest. Mehak Bhatt. So we have come to the end. I think this was question number 20. And congratulations to all of you who have participated so enthusiastically. And I know who are the two ones who have got the fastest, because I kept a track, but we will allow our IT team. And I am sure we are not going to have any other questions anymore. No time.
Immediately you start at least 2025 pilot study and result is required.
Mr. Jairaj, please, sir, kindly mute, sir. Mr. Jairaj, sir. Yeah.
So
Right.
I think they have done extremely well today. Questions were tricky, sir. What do you say?
Yeah, there were some of these were little difficult with so many of these immune deficiencies and uncommon fevers and uncommon symptoms. But I think many of them have answered well. And some questions, of course, were a little tricky. But overall, it was a good performance. So let's see that who have been the fastest amongst the winners also, amongst the correct answers also.
Yeah. So, ma'am, we can tell them we just wait for a few more seconds. We will be announcing. Meanwhile, I would also want to make one more announcement on another PG activity which we are going to be starting like last year. This year also we are going to have the postgraduate poster competition for all the postgraduates in pediatrics. Can Abira or Dr. Krishna share the slide, please? This will be electronic form. You need to submit your poster in e-form only. No hard copy or photocopy of the hard copy is also not allowed. So we are going to share a template, one PPT slide. So you need to submit that PPT slide in that format for all your posters. So can you make it full screen? Yeah. And see, this poster is in preparation to our 5th annual conference of Fever Foundation FEFCON 2022, which is going to be held on 5th and 6th of November. And our scientific committee will examine the posters, and they're going to call for top 10 poster submitters for making a presentation. And they will evaluate the posters online. And the link will be shared to you where you can download the template which is shown here. Your poster can be composed of either research template, research based, or it can be case based. And the ratio of the PPT slide you need to use 16:9 ratio. That means the wider screen one. And it should be done in the same format as shown here. And you can download the format as I mentioned. Next slide, please. And some of the guidelines for submitting your virtual poster presentation, as I've clearly mentioned, we only accept electronic posters, e-posters in PowerPoint format only. Printed posters or photograph of the printed posters will not be accepted. And the topic should be related to fever. Please note it has to be related to fever. It can be research-based or it can be case-based. And category of participation, you can use when you register a drop down button to select whether it is case study or whether it's original research paper. And when your poster is selected for presentation, only the first author will be allowed to make the presentation to our esteemed scientific committee. And poster to be submitted as per the template, otherwise it gets disqualified. And your title of your poster, the word should be less than 15. And along with the one single side PPT format, you need to also submit an article related to this case or research. And this minimum number of words in this article should be 500. And the format in which you will send the word file is Indian Pediatrics, the official journal of IAP, in the format you will be sending. The acceptance of the poster presentation is entirely on the discretion of our scientific committee, and their decision is final and binding. So for any query on the poster related things, please mail to us at feverfoundation@gmail.com. And all participants will get participation certificate, and the winner is going to get attractive prizes. So all posters which have been submitted and selected will be available in FEFCON conference. If FEFCON going to be hybrid conference, so it will be virtual platform. There will be a dedicated poster hall. It will be available on the virtual platform. So more on this, you will be getting these links, and we will be sending it to your colleges to be displayed on your notice borders. And also those who have registered for quiz, we will be sending you all by email also all this information. Okay, so please looking for the case, or if you are already having interesting case, kindly present this. And so I think I will just check whether our IT team is ready for announcing the winners. You can tell us. Yeah. Please, madam and sir, please announce.
Visible, yeah. Yes.
Yes, sure.
So, with Praveen and Yash, actually, we are a 2.5-year-old organization.
Yes.
We're actually
So, this was what was my result also, because I was keeping a track. Kunal Kashi from PGI Chandigarh and Jivanshu Dua from UCMS Delhi. In fact, Kunal got, fastest finger first, 5 questions. And Jivanshu, she got 3. So congratulations to the winners. I think they've done an excellent job. I'm so proud of Kunal because he's from my alumni. And also equally proud of Jivanshu because I think she's from Delhi and from Dr. Anand's.
Yeah,
City.
city. Yeah, but they're all students and they're all dear to us. And I think all those who have participated, it's more important that participation is more important than winning alone. But our congratulations to both the winners, Kunal as well as Jivansha. And we will see them later in our final quiz after all the zones have had, and keep it up. And I think the questions which were given today were little easy. Some of them were easy, some little tough. But in the final rounds, you will get little more tougher questions. So get going and get prepared for the final rounds also. And all the best to both of you.
So just to add to that, Dr. Kunal, once again, and Dr. Jivansha, congratulations to you. But I would like to inform you that both of you will be playing as North Zone team. You will not be playing individually for the finals. So you will be representing entire North Zone and you will be playing as the North Zone team. Our team will exchange each other's contact details so you can be working together. And then, so wish you all back. And you will be coming down to Bangalore. So our team will get in touch with your travel and other things. So you will come to Bangalore on November 5th. Is the quiz. So 5th and 6th you will be in Bangalore. So our team, Mr. Praveen and Ms. Abhira will get in touch with you for more details. So congratulations to the winner once again. Winner, yeah. So if there are no anything else, with the permission of the judges and all our colleagues, can we close this meeting?
Yes.
Excellent meeting. Pleasure. And it was so refreshing to have gone through all these questions along with the youngsters.
All the participants will get a participation certificate. So our team will send you this certificate.
And also the quiz masters. We'll also get the participation
because you have put in more effort actually. Lots of work has gone. So thank you all for a wonderful participation. Thank you.